All right, let's dive right into this explainer. Today, we're stepping into the high-stakes decision architecture of cardiovascular emergencies. You know, the exact kind of cases that can totally ruin your shift. This is a realm where recognizing a precise physiological trap can quite literally mean the difference between life and death. We aren't just looking at standard presentations today. We're breaking down those critical moments where a single, subtle variable shifts the entire paradigm of care.
Here is our hyperdense itinerary for today. 1. Acute coronary syndromes. 2. Malignant arrhythmias. 3. Valvular mechanical failures. And 4. Clinical reconciliation traps. Let's get right to it.
Module 1. Acute coronary syndromes.
Picture this at the bedside. You've got a 64-year-old female patient complaining of shortness of breath. Her ECG shows clear signs of an inferior myocardial infarction, ST elevations in leads I, 3, and AVF. So you follow the standard acute coronary syndrome pathway, right? You give her a routine sublingual nitroglycerin dose. But suddenly, bam, her blood pressure tanks to a terrifying 90/50. So, what exactly just caused this sudden hemodynamic crash?
Well, this perfectly highlights the trap we're talking about. Look at this data. This isn't just a standard inferior MI. We actually have right ventricular involvement here. And giving nitroglycerin to a patient with a right ventricular infarct, it literally triggers catastrophic hemodynamic collapse. The choice architecture in this scenario means you have to completely abandon that standard nitrate pathway.
To really grasp why this happens, we need to quickly zoom out and map the pathophysiology. We have to differentiate transmural STEMI occlusions, which involve an acute plaque rupture with a fully occlusive thrombus, from the non-occlusive subendocardial ischemia of an NSTEMI. Both obviously require immediate action, but the precise location of that occlusion, that dictates absolutely everything we do next.
And that brings us to the right ventricular infarction red line. An inferior wall MI, which is usually from a right coronary artery occlusion, can easily expand to the right ventricle. So your absolute diagnostic mandate here is to check a right-sided ECG. Seeing ST elevation in lead V4R confirms the RV infarct. And here's the physiology behind it. Because that infarcted right ventricle loses its pumping efficiency, its cardiac output becomes entirely 100% dependent on venous return, or preload. Because of this, venodilators, things like nitrates, diuretics, and even morphine are strictly, absolutely contraindicated. Instead, you treat this hypotension with aggressive IV normal saline boluses to maintain that crucial RV preload, even if your first instinct is to reach for pressors.
Just look at how this one single variable, right ventricular involvement, completely flips your management strategy. If you're dealing with a standard inferior MI and you've ruled out right-sided extension, then sure, preload-lowering medications like nitrates are perfectly safe. But the second you spot that V4R ST elevation, you execute a total protocol shift. You immediately prioritize IV fluid resuscitation, and you explicitly ban all venodilators.
Let's move on to Module 2, Malignant Arrhythmias.
Consider this clinical setup. A 24-year-old comes in with palpitations. You get them on the monitor, and you see this. In a regularly irregular, wide complex rhythm, absolutely screaming at 190 beats per minute. Now, their blood pressure is currently stable. For a lot of SVTs, your reflex might be to just reach for an AV nodal blocker, but do you give adenosine in this exact scenario?
If you look really closely at this baseline ECG, the answer is right there. Do you see that slurred upstroke on the QRS complex? That's a delta wave. It tells us there's an accessory pathway, specifically the bundle of Kent, that is completely bypassing the AV node. This is the classic hallmark of Wolff-Parkinson-White, or WPW syndrome.
And this leads us straight into a massive interventional red line, the AV nodal blocker ban. The ultimate trap here is WPW presenting with concurrent atrial fibrillation. That's the wide complex irregular tachycardia we were just looking at. In this specific situation, IV adenosine, beta blockers, calcium channel blockers like diltiazem and digoxin are all strictly contraindicated. Why? Because the AV node acts as a natural brake. If you block it, you completely remove that braking mechanism. This shunts all those chaotic fibrillating atrial impulses directly down that unbraked accessory pathway straight into the ventricles. You'll accelerate the ventricular rate right past its structural limits and trigger immediate ventricular fibrillation and cardiac arrest. No joke. So the solution? For a stable patient, you go with IV procainamide or ibudilide. If they become unstable, you immediately move to synchronized cardioversion. So in this case, the low-frequency variable, that accessory pathway, totally dictates our intervention. A standard narrow complex SVT, AV nodal blockers or vagal maneuvers are perfectly safe and effective, but the WPW with AFib variants with that wide complex irregular rhythm means those standard SVT drugs will be lethal. It absolutely mandates that you pivot to procainamide or cardioversion.
Next up, Module 3, Valvular Mechanical Failures.
Here is a frankly terrifying mechanical trap. Let's say a patient with a history of severe, tearing chest pain suddenly develops unremitting dyspnea, rapid cardiogenic shock, and you hear a soft, early diastolic murmur. The heart is failing as a pump. So, is mechanical support with an intra-aortic balloon pump, an IABP, the right move here to support their crashing pressures?
First off, we have to isolate the underlying mechanics. We need to differentiate the slow, progressive adaptations you'd see in chronic aortic stenosis. Think of that delayed, weak pulse, the pulsus parvis et tardus, from the acute crisis we're seeing right now. Our patient is experiencing acute aortic regurgitation. This is likely driven by an aortic dissection that's extended right into the valve. This causes a sudden, massive diastolic backflow of blood into a totally non-compliant left ventricle, leading to instant, severe pulmonary edema.
This exact physiology creates what we call the acute volumetric decompression mandate. Unlike chronic heart failure, this acute severe AR demands a really aggressive vasodilator strategy. You have to immediately reduce afterload, typically with IV nitroprusside paired with a positive inotrope like thiobutamine to forcefully drive that blood forward. You're basically just buying time for an emergent surgical valve replacement. And this brings us to the absolute mechanical red line. Intra-aortic balloon pump placement is strictly banned here. Why? Well, think about how an IABP works. The balloon inflates during diastole to augment coronary perfusion. In acute aortic regurgitation, inflating a balloon in the aorta during diastole will catastrophically blast even more of that regurgitant blood backward into a left ventricle that's already failing.
It's pretty clear how the timeline of the mechanical failure completely dictates your intervention. With chronic valvular disease, that gradual remodeling allows for medical management, diuretics, and a planned valve replacement. But the sudden decompensation of massive backflow from a dissection, that demands aggressive IV afterload reduction and emergent surgery, with an IABP explicitly forbidden.
Finally, let's look at Module 4, Clinical Reconciliation Traps.
All right, imagine this absolute nightmare scenario. A patient in cardiogenic shock crashes through your doors. Telemetry shows concurrent inferior ST elevations and an irregular wide complex tachycardia. Plus, on exam, you auscultate a brand new, loud, hollow systolic murmur. You are simultaneously facing ischemia, a malignant arrhythmia, and a structural mechanical failure. So, in what exact order do you execute your interventions without triggering a lethal trap? In all this chaos, your clinical logic has to be sequenced perfectly. Step 1. Secure a right-sided ECG map to check V4R. You absolutely must protect preload and rule out an RV infarct before you even think about giving a nitrate for the ischemia. Step 2. Define the accessory pathways. You recognize the wide complex irregularity, which immediately locks out all AV nodal blockers so you don't push adenosine and cause VFib. And Step 3. Manage the volumetric afterload. You optimize pressures based on that new structural defect, making absolutely sure you aren't deploying mechanical supports that are contraindicated for their specific valvular failure.
Ultimately, this explainer boils down to these absolutely critical, high-yield error mitigation strategies. These are the red lines you simply cannot cross. Number 1, do not blindly give nitroglycerin to an inferior MI without a right-sided chest lead map. Number 2, do not push diltiazem or metoprolol for wide complex irregular rhythms in young adults. Number 3, do not delay coronary angiography to wait for a troponin trend in a patient with active ST elevations. And number 4, never, ever insert an IABB in acute aortic insufficiency.
When subtle physiological variables shift the entire paradigm of care, running on autopilot is going to get your patient killed. The ultimate question you really have to ask yourself at the bedside is this. In the chaotic intersection of ischemia, arrhythmia, and mechanical failure, are you simply treating the loudest symptom, or are you actively navigating the trap? Keep these red lines in mind, trust your physiology, and we'll catch you in the next explainer.